Good afternoon, everyone. I think we should go ahead and get started. Welcome, tribes and tribal partners, to the PMH service webinar. Andrea Zubiotti, the Chief of the Office of Tribal Affairs, was scheduled to present today, and she apologizes. She had something come up and she is not able to attend, but I will be presenting on her behalf. My name is Stephanie Hockman, and I am a health program specialist with the Office of Tribal Affairs. Today, I would like to introduce our speakers. We have Dr. Yoshi Lang, who is a medical consultant with the Division of Quality and Population Health Management, and Dr. Laura Miller, the medical consultant with the Division of Quality and Population Health Management. She is the lead of stakeholder engagement for the PMH service project. She is a former staff physician and medical director for the Kimowa Medical Center on the Hoopa Indian Reservation. Next slide, please. Thank you. So the objectives for today's webinar are to understand the goals and functions of the PMH service project, how the service project has gained and employed a tribal perspective, specifically in the areas of data sovereignty and health disparities, what the next steps for tribes and tribal partners looks like, and what the opportunities are to voice feedback and give input. Next slide, please. Thank you so much. So the service project has identified 5 specific guidelines for engagement with tribal communities. The first one is a commitment to understanding of tribal healthcare network in California. The second is an adherence and recognition of tribal data sovereignty. A third is a respect for the diversity of tribe and tribal experience. Upholding and confidentiality of tribal consultation materials. Consistently seeking early outreach and frequent requests for input from tribes and tribal partners. And with that, I would like to turn it over to our first presenter, who will be Dr. Liang.
Thanks, Stephanie.
Thanks,
Thanks, everyone, for joining today. You can hear me okay? Okay, great. So I'm going to just give the very broad vision of what this thing is, the PHM service, and then we will get into more specifics relevant to tribes. So the vision of the PHM service is that this is to improve the health of Medi-Cal members. Ultimately, that's what it's all about. We're also trying to reduce disparities, and we're going to do that by providing this data-driven solution, and it's going to support whole person care. I'll talk about what we mean by that a little bit, and population health functions, and I'll talk a little bit about what I mean there. And then the service is going to integrate data from a bunch of different sources. So it'll be healthcare data, behavioral health data, social services, even corrections and justice involved data. We're going to get all that data, and then we're going to be able to share that with the various entities, including members directly, all for the purposes of providing services and filling in gaps. And again, ultimately, this is for members and to try to enhance Medi-Cal members' experience with the Medi-Cal program. When I say whole person care, what I mean specifically is something like care management. So, right, our sickest, most vulnerable folks should have a care manager, and that care manager needs information. For example, is this person enrolled in WIC or CalFresh? Are they eligible for these programs? And if we can provide a care manager with a flag that says, hey, this person is eligible for WIC or eligible for CalFresh, we can get them those services much more easily. And then with population health, what we mean is taking a specific group of folks and providing health to them. Probably most people don't explain it this way, but the way I think of it is it's sort of in between public health and healthcare delivery, where this is the healthcare system saying, hey, we want to take care of this whole population. How do we better serve them? And that takes data. to be able to provide services that are missing. Okay, so next slide to talk a little more specifically about what the service, what we want or what we envision the service will do for members is here. So we know that it's difficult for members to navigate our system, and they're probably enrolled in various programs. So we want to support them in navigating the Medi-Cal program, where they can go to a member portal, where they can see, oh, here's all my benefits and what I'm receiving. Oh, and here's what I am eligible for. And I have a link here that says, here, you can sign up for CalFresh right here, for example. So that's an example of gaps in services that we want to reduce. The service will also have health education information, so you can go there for a reliable educational, for reliable health education materials. And then the last thing is we want folks to be able to easily update their demographic and contact information, because right now we know it can be very difficult to contact the local Medi-Cal office to update your contact information. So we want to make that as easy as possible, because of course we can't help members, and I can't help my patients in clinic, right, if we can't reach them. So the contact information is critical. And then we also can't address health disparities unless we have accurate demographic information. So that's critical as well. So that's what I wanted to cover in terms of the big picture of what we're trying to do with the service and what we're trying to do specifically for members. Okay, and then I believe I'm handing it off to Dr. Laura Miller.
You are indeed. Thank you, Yoshi. And for folks on Zoom, on Teams, please feel free to raise your hand and ask a question. We definitely want this to be a dialogue, not speaking at, but speaking with. We don't have a million slides to jam through, so we can really take our time and have a conversation. So if something I say sparks a question, raise your hand, probably with the icon, because I can only see a very few people. So anyway, thank you for coming. It's an honor to be here. So as Yoshi said, the service really is designed to support the whole person. And when we say whole person care, we mean physical health, behavioral health, and social services. I often say that for doctors, like Yoshi and myself, whole person care came into medicine as a thing, maybe like 20 years ago. Social workers knew about whole person care and the needs of the whole person for centuries, and so I think that whole person care is not new in the world, but it is new in terms of medicine and systems of healthcare, really trying to break out of our clinic box and look at the whole person. So we recognize that people have a multitude of needs and issues: food, legal issues, housing, education, financial, all of those pieces. And we really want to make it such that there is a way to see the whole person, see what their needs are, and how we can support that. I often say that, me in an exam room with a bottle of metformin isn't doing much if my patient with diabetes doesn't have access to healthy food. So really taking the narrow construct of medicine and really making it real and saying, look, there's a bunch of other things that are involved. So we want the PHM service to be an easy to access platform where members can see their information and get access to health and social service programs that they are entitled to. I think our systems are hard to navigate, so it makes it very hard to actually sometimes get what you are truly entitled to. Next slide. So another goal of the service and in part of the concept is that it's multi-party data access and sharing. So all of the circles on the periphery will be putting data in and able to get data out of the service with the appropriate permissions. The other thing to add, and this came up in some pre-work, researchers this is not a tool for research at all. This is for service providers, for health plans, and there will be very clear role-based permissioning. But as you can see, tribes and tribal partners are absolutely a part of this ecosystem. Hence, we wanted to have this meeting to really share what we're thinking about and very much so learn from you all about challenges, about issues around data sovereignty, et cetera, which is why we're here today. Next slide. So this is a graphic, and I like this graphic a lot because it shows to me what all of the example sources of data coming in. So housing agencies are able to have data in, social services, primary care, hospitals. We're also looking to bring in Department of Corrections data, supplemental nutrition, SNAP, WIC, et cetera, all of that data coming into the service and integrating it such that people can see what they are eligible for. Health plans can actually reach out to people proactively and say, hey, you are eligible for this program. Would you like us to help connect you? It's not a system to ration care at all, rather to open up and be able to provide more care for the whole population. And then also we're always looking, how can we improve? How can we improve policy? How can we improve programs for communities? And I think the data that we can get from the PHM service is going to be a part of that. Really looking to improve in a continuous improvement cycle. Super important. Next slide. So we wanted to sort of bring a scenario about how the service might work. And actually, Andrea and I had a chance to workshop this story. So Andrea is here in spirit, if not on the Zoom screen. So this is a hypothetical person, but she's Tina, is a new Medi-Cal member and has just moved into the area. And she has a family history of diabetes. She has indicated through the member portal and or as she signs up for Medi-Cal that she is American Indian and Alaska Native. Because she has a history of diabetes, both family history and her own history, the plan can see that. They can see the diabetes and they can see how she identified herself as American Indian Alaska Native. And then because of that, the plan can reach out and connect her to a local Indian healthcare provider for further treatment. So it's using the identifier, the ethnic identifier, as a way to offer culturally appropriate, culturally sensitive care to her. It's not mandating that she do it, but simply tailoring a resource to her needs based on what can be seen in the system. And so that's the sort of thing that it's a scenario, a use case, if you will, that where we think that the service can be of benefit for people, for members. Next slide. So this is just a quick look at where we've been and what we're doing. So we're right here in the bright gold arrow, January. The story starts at least in March of 2022, if not before. I think the PHM service has been a dream for a lot of people for even prior than March of 2022. But there was a whole significant process for procurement of the system, getting the vendors. Their request for proposals was released. And then finally, by the way end of December of 22, the contract was signed and work began. So really all through 2023, we worked hard inside DHCS and with the vendor. The primary vendor is called Gamewell Technologies, to get ourselves together, to build the implementation plan, to take this idea at a very high level of the service and make it real. Like, how do we actually do this? What inputs and outputs do we connect? How do we do it? What is security? How do we keep data safe? All of those pieces have taken a good deal of time. But I have to say we are cooking with gas now, which feels really good. So in November, we reached in the process of doing the stakeholder engagement. Andrea Zubbiate was a commenter on the plan and really highlighted that we need to absolutely and in a focused manner work with tribes and tribal partners to make this service appropriate. Andrea's done a lot of good educating of me and others on data sovereignty, what that means, how we need to respect that. And this is a continuing conversation. And in part, that's why we're here today. So in December, we did a lot of research around data sovereignty. We've also reached out to subject matter experts. I guess I'm now in the gold January era. We've engaged subject matter experts. We're having the webinar today. And so we're really beginning that deeper engagement with tribes and tribal partners around the PHM service. So for the future, we plan at least 3 public webinars and 3 working sessions with tribes and tribal partners to dive deeper into the service. What will it look like? How might it be used? What concerns do you have? And then a lot of that is what we call configuration. What is it going to look like? Those pieces. And then ultimately, when the service is launched for tribes and tribal partners, there will be user acceptance testing and training. You can't just fling a new system at people and expect them to use it. And we built into this whole process multiple cycles of feedback. And I really consider today, one of our first points of feedback. I'm one of the people leading the user and stakeholder engagement and super happy to hear from people, engage, and really work together to make it what we want it to be and have it be a helpful and useful tool. Next slide. So this is just a little bit more granularity, a little bit more detail on what we've done. So we've worked really closely with the DHCS Office of Tribal Affairs for input, working back and forth and really making our language and our understanding concordant. I think the case example of Tina is a really good one. That was me and Andrea working last Friday afternoon to get that one together. We've brought together this group, the Tribes and Tribal Partners, to begin to talk about the service. We've had subject matter expert input, and that will continue. And we are doing ongoing research to really prepare to partner responsibly and to prepare properly, prepare documentation, all of those pieces. Next slide. So things we've learned, in terms of tribal healthcare, we know that care is primarily provided by tribal health programs, and really acknowledging and knowing that tribes assume control of healthcare services from the federal government, ensuring community values. And also, California is the home to the largest population of American Indians. So both federally and non-federally recognized tribes, as well as tribal members from other states. In terms of data sovereignty, again, definite learnings I know for me here. Oftentimes data that gets passed to government agencies and returned to tribes can be inaccurate or have data suppression issues. When the absolute numbers of a population are very small, that data can be suppressed to protect privacy, but also it has a negative flip side in that certain groups, tribal groups and members, might not be recognized in the data, and therefore we completely don't see disparities. We also know that racial misclassification is a significant issue, with 40% of Native descendants classified as white in their death certificates, which again muddies the waters completely and does not help us understand. And then in terms of data stewardship, we know that we will need to have safeguards around what data is collected and what it will be used for and who can access it. Again, I mentioned that piece about researchers not having access. That is like, I don't think researchers accessing this data has ever even been thought of in the plans. So this is not a research tool at all. And really, we are learning. I know that I am learning and really looking forward to building with you. We know that tribal experiences, the experiences of tribal members differs across time and space, but we really want to learn from you and gain insight. So I think with that, we're at the 22-minute mark. I hope I have not bored you tremendously. It's been hard. I can't see faces. At this point, we would really love to open up a dialogue. There is Poll Everywhere, which I understand has been used before. The question that we're going to address first is, what concerns do you have? Like, what is worrying you? What do you want me to know and us to know as we're building the service? So you can scan the QR code. It'll take you to a Poll Everywhere, and you'll see Vincent's name. And then you should be able to type in words about your concerns. So we're going to get a little bit of time for that. Hopefully the words will start to populate themselves. I'm going to do it myself, not that I am going to say anything, but I want to make sure it works. Apparently there will be a screen name, so I guess I am going to do it.
I'll test it out too.
Okay. I'm going to just say, will it work? ? And submit. So it should pop up on the screen if life is good. There we go. Somebody else besides me is saying stuff. Awesome. Okay. Fling in concerns, please, everybody. And really, there's, anything.
I just copied yours, Laura.
Okay.
So we know it's me and not one of our participants.
Awesome. No concern is too big or too small. Great. How will the data be protected? I love it. That is a very important question, and one that we've been working on for forever. Not forever. That's an overstatement. Great. Helping tribes understand what data sovereignty is. It's a great one.
This has never been done before.
Yeah.
California is the first state to try to implement what we call a PHM platform. And typically PHM platforms are implemented either at a health plan level or a health delivery system level. Like Kaiser has their whole kind of PHM platform in the background. No one's been crazy enough to do it across a whole state.
And that makes it challenging. We are a big state. And and there have been local solutions that have been built up in areas of the state. So many, if an area already has a solution, they may be thinking, why should I go with you, DHCS? I've got my solution. Do we have more questions or concerns? Because we can begin to answer some of these, but then also it's not like we're one and done and we've got a solution and an answer and we're done. You know, it's the beginning of a conversation. That's a great piece. Worried that the data may not be up to date, especially if it's claims data. Absolutely right. Claims data lags. It absolutely lags. Anywhere from 1 month to 6 months is generally what I think of when I think about claims lag. One of the things that we say about the service is that it is not a real-time electronic health record. You know, and there will be lag for sure. I think we are thinking as we bring that the value of it will be bringing in data from multiple areas. But yes, the lag is there. Yeah, and we have to name it and say it and still have the service be valuable, even though there is claims lag. Yeah. That makes, yeah. I think that, well, one of the things that we are doing, especially like explaining the value to members, is we will be doing stakeholder engagement with members as well. Absolutely. Talking to people, what are their pain points with Medi-Cal? And how can we help solve those? One of the things that we've thought about is that you know, if you have to change your address, that can take a lot of time and be really challenging. And so if people could go into a portal, and a portal that they may already have, to be able to do that, that can be a value add for them. I love this piece around funding with training to update systems and technology. I don't, certainly building partnerships to reduce disparities, absolutely. I don't know in my own mind right now if there is funding for tribes to update systems and technology. It's not something that I think we are thinking about in the context of the service. And I wish Andrea were here because her finger would be more on that pulse than I. But we can certainly take that question back and try to figure it out. I totally get it. I mean, yes, I totally understand that. And then to the question, is it duplicating existing services? I think that it depends on where you are. We were just talking about this in another meeting. Like health information exchanges, HIEs, again, Southern California, San Diego, it's pretty well developed. The HIE where data from different parts of the systems, physical, behavioral, social services can be seen, but not everywhere. Like I've done primary care in Alameda County and we barely have something that might work. So it's really different. It's different from place to place. And I think one of the ideas of it being statewide is that it will be a single platform so that when people move from one place to another, their plans and their providers and they can access the same system. Let's see. Difficult to explain. We talked a little bit about difficult to explain the value to members. I think we have to make sure that it is valuable to members. I mean, that's a key thing that is front and center. Is we want to be able to improve member health and make things easier for them. Absolutely. And that I think, as we continue our conversations around the service, hearing from lots of different people about the challenges that members face will help us make it better. I know I missed some down below.
Yeah, I wanted to address the value of the tool will be more for large organizations and not for Medi-Cal members. And I think this is definitely a valid concern. The very first concept of the service was it would be sort of twofold for Medi-Cal members and to support DHCS and monitoring the Medi-Cal health plans out there to make sure that they were providing services and high quality care. That was the original idea. And then our deputy director, Paula Barbaria, when she looked at this plan, she said, well, it could actually do more than that, because this could be a tool for the Medi-Cal health plans, and it could be a tool for healthcare providers and service providers like the care managers. And that made a lot of sense, right? To let all these or kind of enable all these different entities to be able to plug into the same data, all for the benefit of helping members. So it is valid to say that this will be a tool for both large organizations and Medi-Cal members. But the North Star is that all these larger organizations are getting this data in order to better support Medi-Cal members. So I hope that makes sense.
Yeah, I think that's well said, Yoshi, in terms of just what are we thinking about? Yeah. I see the piece helping tribes understand what data sovereignty is and how data will be used. I think that is the right interpretation there. I mean, I'm learning about data sovereignty. I am not, the best speaker on that. I mean, I do understand at a basic level that, tribal data is important, and tribes must have say over what happens to their data. So I think that is an important concept that I am certainly getting clearer on. And then perhaps the second part, how will the data be used? I think we've been talking about that in terms of used to help direct services to people, make sure that people are getting what they are entitled to. And in the case example with the woman, Tina, she got outreach from her plan, recognizing both her risk in terms of her diabetes and directing her to culturally sensitive care because her tribal identity was known. Her identity as an Alaska Native American Indian was known. So I think that's some pieces of it, and I think we can have a continuing dialogue about that. I do see the piece, how will data be protected? I feel like, and Yoshi can keep me honest here, I feel like we have talked about that. There's so many protections involved here. I feel like 3/4 of our dialogue to date has been about keeping the data safe. I don't know, Yoshi, if you want to expound on that more.
Yeah, I'm a physician, not a data security person, but I do know that the department takes it, and I see this basically every day, that the department takes data protection extremely seriously. In fact, that if there's something that's going to delay the project, it's probably making sure that all the security documentation and systems are in place. So there is very thorough vetting of deliverables, basically documentation coming from Gainwell that we review. And then also a third party, another company that comes in and does an independent review to say, hey, is Gainwell doing all the right things with DHCS to protect the data? So there are many safeguards in place. So that's what I would want to share with everyone.
Yeah. And I mentioned briefly the role-based permissions, basically depending on where you sit and what credentials you log in with depends on, or it allows you to see or not see certain things. So I could log in as, if this were true, I could log in as an employee of a health plan and be able to see people who are in my plan, or I could log in as a member and see myself and my family. That's the sort of role-based permissioning. So all of those things are in process, and we're working on them. Let's go down to that very first one, understanding what data from Native communities will be used for the service. I mean, that's really what we're thinking and talking about now. I think that's the dialogue that we're in. It's not going to be the state coming and saying, give us all your stuff. I think that's what we're trying to figure out now. When people sign up for Medi-Cal, they do check a box for American Indian, Alaska Native. So that's in the system. Medi-Cal claims linked to that person are in the system and can be seen as, a data point around someone who is American Indian, Alaska Native. So, and as I say, I think we're working this out as we go. But I appreciate the questions. Vincent, can you go up maybe? And certainly if people want to come off mic and ask, yeah, please do so. Got it. Totally confusing to understand. Totally get it. Yes, we do want to make it accessible. We can certainly distribute this deck. We can work together to build something that would be more accessible. And that's something that I would want to do, certainly, not on my own, sitting at my desk in Oakland, but with others to make sure that it makes sense. This deck will certainly go out to the listserv. I guess I'm saying that, I haven't asked, but I would think we could send it out to everybody on the listserv that got the invitation for this. And then I think it will be a continuing conversation.
And I have a draft of a one-page summary that's been on my back burner for a long time.
Yeah,
but we will finalize that and get it out.
I think maybe Vincent, if you could go to slide 8. If I were to give one slide or work on one thing, this is what comes to my mind as a way to explain it. And it may not do enough. But if I had to pick one thing to take to a desert island to explain the PHM service, it would be this slide. A bunch of sources that don't talk to each other, all getting mixed together and putting out data that helps both individuals and their care and improving policies and programs. But Yoshi and I have tried to explain this to family, to friends, to a lot of people over the past year. We're getting better, but it takes time, and I'm certainly open to ways of doing it better. Let's go back to Poll Everywhere. We have one other Poll Everywhere question, which is, so if we did your concerns, let's do opportunities that you see. So it seems like folks are comfortable with Poll Everywhere, so I won't impose myself on the screen, but let's just work on, throw down some opportunities.
I think there's also a question in the chat that says,
Oh,
are
awesome.
urban Indian health programs included?
I did see that, Sam. Thank you very much. And yes, yes. Absolutely. And that was the voice of Samantha Ross. Sam and I work very closely together, leading the user and stakeholder engagement work. Yeah. Definitely that theme of connecting people to services. I remember hearing a while ago about connected EHR systems and somebody saying, yeah, we make patients be the carriers of their data. I used to tell my patients, print out, I'm going to give you this printout, hand carry it to the consultant. Like, we don't want that to be the case. We want a system to be able to hold the information and carry it and not make the patient be the carrier of the information. Agreed. More accurate demographic information. Yeah. And I think the other piece here is that a lot of this, the main place, and Yoshi, correct me if I'm wrong, but I think it's fair to say the main place that we get the ethnic information is from when people sign up for Medi-Cal.
That's correct.
So yeah, I think that is a really important piece. I see another question. I saw the chat question. Will the service do anything like help close the loop on referrals to places like housing programs? That is such a hot topic. I swear the meeting I have right after this one is considering that issue. So we don't know yet what policy is going to be around that. But I think it's fair to say that if I were I would say a care manager, and the person I was taking care of, oh my goodness, I'm on the screen looking bizarre. If I were a care manager and the person I was taking care of needed housing or was already hooked up with housing, I would be able to see what housing org they were with. So I don't know that it's going to magically show the closed loop, but it would show that the other organizations that are taking care of the member.
Yeah. So in the contract DHCS has with Gainwell, closed loop referrals is called an optional service. So it's not something that's planned to roll out in the initial release of the service. But it could if the department DHCS chooses to basically build it and make it work. So I think that's the answer. The other caveat, like we've been talking about, is that the data, at least in the initial releases, will not be real time. So it's not like it could be the tool to track the referrals, but it could be a monitoring tool so that DHCS could say, hey, is this health plan actually making these referrals happen and making sure members are able to get that service? We would be able to see that.
And I think see again, like what other organizations are supporting a person. Yeah, on the duplicative referrals, I think that's a to be determined. Because one of the things that I try to remember with the service is that we're not trying to replicate somebody's electronic health record at all. And I think of referrals as very much at like the patient care level, and referrals going into a system and getting faxed or getting sent electronically. I don't think the service will be as real time as that. So I can see how it will help with understanding a person's needs, but I don't know if we can say that it really will help with duplicative referrals.
That is certainly a hope, but it may not happen initially if there's too much lag.
Yeah. And then I was recently on a call with folks in a system who have what they consider to be a good closed loop referral system. And they're saying, "Ooh, we don't want to give it up. We like what we have. We don't want what you have." So or we don't want what you're planning. It's going to be a process. It's definitely a conversation. So just emphasizing this is the beginning of a conversation.
One related thing to duplicative referrals is we know that sometimes members have to fill out various screening and assessment forms repeatedly because there is no source that's keeping all that data that they've already filled out on a form. And so if that's something that DHCS tracks or holds data on, then that's something that could be in the service so that that person wouldn't have to repeat those screenings and assessments.
And Brandon Betancourt just threw that in the chat as you were answering it, Yoshi. So that's, yes, the cutting down on duplication of screenings and really re-traumatization with screenings about the same thing is absolutely in our sights.
Yep. Yeah, we didn't go into all, I'm realizing we didn't go into all the capabilities of the service. For example, screenings and assessments is one of those.
Yeah. And we wanted to keep this really, because it is complicated. It is a challenging thing to understand. We wanted to keep it really high level and just begin the conversation. What referral program? Let's see, what referral program or service do you recommend if we don't have one yet? I'm not sure. I don't have enough context to be able to answer that. About do you feel comfortable coming off, going on mic to talk a little bit more about the service we might recommend?
Sure, no problem. Hi, my name is Felicia Batson with the Fresno American Urban Indian Health Center here in Fresno, California. So if we have a community referral system or opportunity, is there one you guys prefer or recommend over the other? So like there's Unite Us, there's Aunt Bertha, there's an Apricot 360, there's one that, I don't know, depending on your EHR you could use. What should we do if we don't have one?
I don't think we should opine, not to be a pain, but I think that the two solutions can live alongside each other. So like Aunt Bertha or Unite Us, that really is more of a real-time referral and linkages platform. And there's also like Point Click Care is another one. There are a lot of these out there. I don't think we have a recommendation.
Okay.
I know that in Alameda County, when we were looking at EHRs, we wanted Epic because everybody else was doing Epic. So there is kind of a utility to going with what is winning in your area, to get the more people involved. But yeah.
Thank you.
Yeah, no problem. It's a good question. And then another one, opportunity to reevaluate policy, sovereignty, and medicine systems of care. How can we include traditional services of Native health? I mean, that is a really good question or statement. Yeah, And I think for me, I would really just want to engage in a conversation around that. I think it does come to, being able to look at policies and look at health outcomes, and how can we improve those? I know
I'm
that
very intrigued by the idea of including traditional services of native health. But we would have to learn more from all of you to figure out what that would mean.
Yeah. I want to be really respectful of people's time. We'll definitely, as we've said, this is the beginning. Absolutely. We will send out this deck. I'm going to put my email in the chat. If you have questions, concerns, I'm certainly glad to try to answer them. And then we will absolutely be in touch regards next steps. That's my email, and I spelled my name right. It's a miracle. And really, Vincent, if you could pop up slide 9 again, it's sort of our arrow map. We're certainly super interested in your response to this whole conversation and concept. And then we'll be reaching out for more formal engagement around really having tribes and tribal partners have a voice and a say. One thing I would really beg of you is, I don't know how many people we have, but I think our list was much bigger than the number of people here. So I would really encourage you, if you have time, to sort of spread the word, let people know that there's this PHM service happening, and we really, really want to hear their voice.
Last thing I'll say is that the name will likely change. PHM service is just what we've been calling it, for lack of a name that we may end up trademarking something catchier. So just a heads up there. But thank you so much, everyone, for your time. I'm really glad we were able to get an opportunity to kind of introduce all of this.
Absolutely.
And hear from you.
I really appreciate the poll everywhere. We'll take a look at those questions again that we gathered in the poll everywhere and see if there's a way that we can maybe turn that back around into a document. Is that something that folks would find helpful? I got a yes. Okay, we'll take that then. And again, just really appreciate presence and the beginning of this conversation. Thank you so much.